And if somebody, two more people show up, then we'll be good. So welcome, 2025 Remac meeting. I'm honored to be here. Thanks for your votes. It's a contested election. If I could do half as good a job as Pam, I'll be very happy with my performance. And Bill's going to be helping me until my Amazon version of Robert's Rules of Order comes in. So, roll call.
Okay. Dr. Papish.
Here.
Dr. Larson. Dr. Stubmiller.
Here.
Dr. Leno. Dr. Coussard. Dr. McGinley. Dr. Kim. Dr. Chung. Dr. McGurdy.
Here.
Dr. Brook.
Here.
Dr. Stupple. Dr. Templeton. Dr. Rasquella. Dr. Raybridge. Dr. May. Dr. Rowntree. Dr. Spano. Dr. Rodriguez. Dr. Breville. Dr. Ahari. Dr. Santos. Dr. Felice. Dr. Wolf.
Here.
Dr. Kakuza. Dr. Quintero.
Kakuza represents the Medicine.
Yes, yeah, as a level 120.
Deforming a list of people in there.
We have 5, so there's short 3 people for a quorum.
All right, so can't really vote on anything.
Right, we'll be informational on this one.
And the minutes, we can't approve the minutes.
No.
So, anybody have any questions about the minutes?
I sent them out this morning at 7:05.
We can review the minutes at the next meeting. Old business. Supraglottic pilot program update.
We gave all the paperwork to the state and actually wrote the policy for them so that it would be easier to do. Like the ASF, they don't have to make it, they just have to improve on it. And we're just waiting for that to come out.
So when is their next meeting?
The state?
Yes. And
Well,
when is CMAC?
so CMAC SEMSCO, the next one is February 26 and 7, or
6 and 7.
26 and 7, which is a Wednesday, Thursday versus a Tuesday, Wednesday. And it's really whether the state, it's up to the state now to put the policy out. The supraglottic was put into protocol as a supraglottic airway, not the iGel. And it's just a matter of the policy statement coming out from the state.
That's an awesome accomplishment.
Yeah.
IV fluid conservation. Sounds like that situation's pretty much resolved. Anybody still hearing anything from their hospitals?
Yeah, we cannot get IV fluids, period.
Sorry.
Yep.
Really? Just
Yep, and most hospitals have said we're not restocking your IV fluids pre-hospital.
it's interesting because like all of the, at least at my facility, all the warnings have kind of mitigated. No one's really harping on us to conserve. Are you finding that?
You guys?
You have to, when you still have a drop
Where do you
down.
get it?
They still have it?
You do the warnings, but you can eliminate it,
We have
but,
a little small up in
yeah,
downstream, we have a small
fully
up
stocked.
Medical warehouse would be pretty good.
Medical warehouse doesn't have any more.
They have
As
small
of
bags, so if
Friday.
you're willing to get smaller bags, like they have some, if you're, willing to like mix up with the house, but we gotta put the ground there, and then we just, try really hard to help with.
Yeah, so we looked at Cardinal Health also, and they don't have, there's some things on along that the next delivery that is possible is somewhere in February.
So what do you have? Do you have a stock of anything?
So we're using saline, the 10 cc saline and starter line if you need to give medication, otherwise conserve as much as possible.
So you don't have any bag, like physical bags?
We have 500 bags and we have 100 bags.
Okay, so you still have a
But
little.
we have, you know, we don't have an ability to get much. That's not so, it
I
sounds
reach
good
out
that there's
after
some
and
other
see if I can
places.
help you guys, you know, I
Sure.
have to reach out to them and see.
Yeah, great.
Yeah, my guesstimate is this problem is pretty much, like, you know, barring another blizzard or whatever caused that factory to shut down.
Yeah.
Be done.
Yeah.
All right, service upgrades. Read them into the minutes. West Clinton Fire District, 12 lead, as of November. Tallman Fire District, albuterol, glucometry, and Narcan. Town of Highlands Ambulance in Sullivan, albuterol, Narcan. Upper Delaware Back, glucometry. SYSO FPPR 1514, PAD. What is SYSO?
I don't even know what that is.
Well, at least
It's
they
a
have
company
different
that put
word.
in for an application for
Yeah.
that.
Okay.
It's a private.
Private corporation.
Yes.
Evaluation Subcommittee report, I don't think there are, do we have any cases? We had the last two that were resolved.
We had the last two, I don't think we'd ever discussed them, because we were waiting for an outcome, but
Okay, so there's no movement on that, Joey's not moving.
Yeah.
yeah, there was no movement on that.
DOH enforcement notifications. So the big one, please be advised, as a result of an investigation in Rockland County, Ramapo Valley Ambulance Corps, for multiple violations, Part 800, is, their certificate is revoked effective October 17th, 2024. And Corona Community Ambulance Corps, for violations of Article 3012, revoked effective 12/2/24. John Keever, certificate revoked effective 12/9/24, and a $2,000 penalty for Part 800 violations of Worcester, New York. Kadisha Garcia, Brooklyn, New York, Part 800 violation, assessed a civil penalty of $12,000. $8,000 stayed pending no further violations during the period of probation, suspended for 1 year, effective 11/26/24. That's the biggest one I've ever seen. Christopher Pieluk from Farmingdale, New York, for Part 800 violations, certificate suspended for 1 year, effective 11/22/24. Carol Utar of Woodhaven, New York, assessed a, it's like inflation, assessed a civil penalty of $12,000, $10,000 stayed pending no further violations, suspended for 1 year. Stephen Stinson, assessed a civil penalty of $4,000, $2,000 stayed, pending good behavior, suspended for 1 year. Niagara Falls. Wayne Allen of Gloversville, New York, summarily suspended pending a hearing that seems to have already happened on 11/24 for Part 800 violation. So, it doesn't that really update it?
Good thing
Fines are going up.
Yeah.
Helicopter.
So the helicopter committee met this morning before this meeting, and we discussed operational activities, medical activities in the region, and most of the meeting was discussion of blood products pre-hospital. The New York State Blood Products Advisory Group met on December 16, 2024. This was a group that was writing proposed regulations for air ambulances to carry blood products in the state of New York. With the passage of the bill last year that allowed ground ambulances also to stock and carry and administer blood products, this working group is now more general writing for regulations on pre-hospital blood in New York. Because of that, these have not been submitted for review. Once submitted for review, often it takes somewhat of 12 to 18 months to review. after which there is a public comment period. And then if there are substantive public comments, it comes back to the group to rewrite, to resubmit, to have another final public comment period. So the normal timeline from when regulations are submitted to when they are in effect is 2 years. So we are looking at probably another 2 years before any such regulations would be published, and we would have to fall under them. So the now Division of Emergency Medical Services and Trauma Systems has taken over the certification licensure of ambulance transfusion services. So now any services that wants to become an ambulance transfusion service under current regulations now goes through EMS and Trauma Systems, not Wadsworth. The question then will be, will then the region have some responsibility of monitoring and enforcing regulations for ambulance transfusion services? And the answer is we're not sure, but just as a warning, this group may be asked to be part of a regional, Remac to Rensco, monitoring and enforcement of ambulance transfusion service regulations.
It's good stuff. That move is kind of a positive in our direction.
I was under the impression that you carry transfusion blood with your ambulances.
We do.
So
This is ground.
Ground was now, the air ambulance bill was end of 2022, and so we started writing regulations, and then the ground ambulance bill to carry and transfuse is 2024. And so the 2022 regulations we were writing over the last year and a half weren't ever submitted because of the anticipation that ground was going to also be legally able to carry blood, and therefore regulations would be more general for out-of-hospital services, pre-hospital services providing blood.
that's not the case yet.
They are able to, but there are no regulations, and I'm not aware of anyone that has applied to become to carry their own blood. Different than the ambulance transfusion service, which is the service now that does inter-facilities, has to have agreements from sending hospital to receiving hospital, and be licensed by Wadsworth in order to be an ambulance transfusion service. That's the current regulations. Now ground ambulances will also be able to have their own blood, bank it, and administer it.
But it's gonna probably take
Long
another
time.
2 years before even regulations are applicable. Probably no one's going to do it until there's some framework. I imagine.
So let's say, for instance, if in a hospital patient's dissection or whatever, bleeding and endovascular surgery has to be transferred, it's legal for ALS to transfuse during that, emergently during that transfer.
If that ALS service is designated by the state as an ambulance transfusion service.
Currently, that's in place.
Yeah. And if that ambulance service has an agreement with your
Receiving.
hospital and the receiving hospital blood banks, that they can administer the blood from transferring hospital to receiving hospital. So that's the current regulations. The new law says that an ambulance service can contract with the blood bank and store its own blood and administer its own blood. That's emergently. That's the new law that was passed last year. The air ambulance law was passed now 3 years, end of 2020, so just over 2 years ago. And that's when the regulation writing started. But it never was submitted because now the ground ambulance has the same ability to contract with a blood bank, store, buy blood products, and administer them. So.
So the interfacility system already exists as long as the interfacility transport agency that's picking up the patient that has an agreement in place with the hospital and the receiving facility, which is very difficult and laborious, but a lot of agencies have done it. Empress does it. I'm pretty sure the agencies near, Hudson Valley have done it. But this is, the next step is just ground ambulance.
They would have, that's just the staff team.
Yeah, they all have agreements in place. Yeah. But this next pull forward is for actually grand ambulances, the agencies themselves to store blood, carry blood, if they plan it and want to use it, so that they can respond with blood.
I'm kind of scratching my head because to me, the blood bank, at least at a hospital, there's such difficulty in keeping over 8, 10, 12 units. How is an ambulance?
We discussed that at the meeting. It's kind of an interesting scenario. We'll see what happens.
Yeah, the air ambulances maybe have a benefit in terms of, at least Air Methods, like that in New York, is a national company, so they can have the benefit of being a national organization that has national agreements, like with the American Red Cross, to provide blood to its bases for its helicopters. So a small ambulance service unlikely would have the ability to contract, purchase, buy, store, meet regulations, and transfuse. So it's likely going to be a larger organization, or one that has committed the manpower, record keeping, money in order to stand up a blood, storage and transfusion service as part of their.
You could see this as like a supervisor truck, carrying the blood, and the 30 ambulances underneath it not carrying it, and then the supervisor responding to calls that actually might need blood. Something like that in our system would be feasible. But I agree with you. If every ambulance had a unit of blood, there'd be no blood for anybody inpatient. More to come.
Thank you.
All right. RTAC. I guess there's no RTAC.
Yeah, there was.
Oh, that's right.
Yeah, there was an RTAC meeting, 12/12/24. It was done by WebEx. The Westchester Medical, Katie McGuire, gave a comprehensive PowerPoint presentation on transfers to Westchester Hospital and Maria Freire Children's Hospital, including the transfer times for adults and PDs. The transfers that they're having. It was very interesting. Length of stay was included, and a lot of outcomes. So it's been pretty positive on there. There was also some discussion from the Syracuse RTAC, where community hospitals were involved in the RTAC from the beginning point, so that they knew what the RTAC was looking for, or the trauma centers were looking for. And that's one of the things that I think is going to come out of this, because the Hudson Valley RTAC seems to think that it was a good idea to start to include community hospitals in that, so that they know what the trauma centers are going to be looking for. They're going to try to develop some assessment and triage tools that a community hospital can use to make sure that they go to the right level of the trauma center. There was a lot of dialogue about pre-hospital communications, and most of the trauma centers are using the MIST card. I don't know if everybody's familiar with that, but they are using it, and a lot of them said that they keep that by the phone, so now when a call is coming in, they can request the information. If it's not given by the EMS provider on the phone, they can request it. So they want to make sure that providers are aware of this. We brought it up at all our meetings and our REMSCO meetings to make sure that they're aware that they should be using that MIST, and the trauma centers are supposedly stopping for a 30-second period to listen to what EMS has to bring into them. So hopefully that system will work. I think that was about it. Other than that, they said that they'd like to get more participation from EMS. They want to increase their EMS engagement, so they're going to have some topics that are specifically going to be EMS at the RTAC, and then the bringing in of community hospitals on the next agenda. In the MIST thing, the one thing that they did mention was the GCS scores are much more important, and they're using them a lot more frequently, so they like to get them on all their reports. Glasgow Trauma Score. Glasgow Coma Score is what they're looking for. All right, that was it.
QI.
So we're not working on too much. We're going through the previous year's dashboards, and we realized out of 177 agencies, we are missing probably about 25 agencies' data. I've worked with the state, out of all of those, I think I have 2 missing currently. Everybody else is coming in, so this year's dashboard is going to be our most accurate at this current time. Otherwise, we have nothing new.
Business. Protocols, Bob.
No, Bob sent an email and he said, unfortunately, due to an emergency, he wouldn't be able to attend, but he expresses his dearest apologies to everybody.
We'll look forward to an update in the next meeting. Westchester Remac report.
Good morning, everybody. Main thing to give, which I mentioned in the helicopter meeting, just for awareness, is that under Dr. Larson's Westchester Remac hat, he put a tag together starting back in this November of last year's meeting for the consideration of usage of a field physician / field surgeon for very specific criteria, which is yet to be determined. The tag was formed. Dr. McGurty happens to be on the tag wearing his Westchester hat as well. And there was one WebEx meeting last month. There's another one held at the end of this month. And the information will be compiled with the generalization that Westchester Medical Center would be the lead facility that would provide such physician whenever the criteria is developed. And those physicians would be cross-trained under the Special Ops Division of Westchester County Department of Emergency Services to give those physicians some general field training of things that they may come across in their travels. They wouldn't be the ones using the tools for the extrication itself, etc., but for an awareness level of what would be involved. The Chief of Special Ops agreed to do this training when all this gets put forward, and we'll see what this month's tag brings. And then the next Westchester Remac meeting is scheduled for the last Monday of this month, so it should have further by the time you have your next meeting. End of report.
Okay.
Thanks.
Good stuff. CMAC. I guess there's no CMAC report.
Sure. Yes,
David
from
is one.
December.
Oh.
Yeah. We had this sent out to everybody, so you should all have a copy of this. If you want to fall asleep at night, definitely go through this. Just some big things that came out. The Clinical Data Integrity Tag is meeting in a couple of weeks with all of the vendors, PCR vendors, the state and folks to be able to ensure that data gets from agencies to the state, to the regions, and to the hospitals. Because it's not all getting there for a variety of reasons. Some of which is coding, some of which is on the back end, some of which is people not putting data into the PCR, some of it, for some reason, just not getting to the state. And so we're doing a root cause analysis to be able to determine what's going on. What we would like to do is allow all PCRs to get through, period, and not have any blocks, so that we can then go back and see what the issues are with the PCRs and address those issues with either agencies or regions. But right now, if some of the data is blocked because it's failing the state report, that data is not going anywhere. And so we're trying to change that. The collaborative protocols were approved. The change log should be online now, and it should be implemented by July 1st for agencies. There's a bunch of different changes in there, so take a look at the change log. Max dose, 5 max doses of epi and cardiac arrest, vector change for refractory shockable rhythms, New York maple syrup for hypoglycemia.
Makes sense.
Just New York, and they did that because I think it's Vermont has Vermont maple syrup in theirs only. Can't use New York maple syrup in Vermont, you'll go to jail. Don't do that.
Tariffs.
SGAs for EMTs of regionally approved trained and equipped, PEEP, and there's a bunch of other things that are there. So that stuff is there. There's a glucagon pilot project coming out of Suffolk for BLS providers to give IM glucagon in the absence of ALS. And next MSCO is 26th and 27th of February, and then May 6th and 7th in Saratoga after that. They are looking at data in the EPCRs to see the difference between ambulances arriving at the hospital and the time patient care is turned over, just to clarify exactly that time. And what they expressed was really the need for local engagement of agencies and hospitals in a variety of ways, not just some edicts coming out from the state about stuff. The SEMSCO approved to send a letter to the commissioner seeking a 2-year extension for the community paramedic demonstration program, and also to the commissioner to advocate for EMS being an essential service. And those were sort of the highlights out of that 2-day meeting, unless Bill, you have anything else, or I misspoke in any way, shape, or form.
I think we're good. Covers a lot.
Great.
Thank you. New business. Do you want to, we can talk about it after, or do you want to bring up the QA issues? It kind of tails into what he was saying about
It's up to you.
getting data.
Do you want to bring it up now and see what everybody thinks?
Well, there seems to be some issues in us as the Remac getting charts direct from the state when we have QA issues directly. Correct me if I'm wrong about this.
Well, I'm
And
getting
so-
most of the charts now. The problem is getting the agencies to actually report, or the hospital to report, a decline in patient deterioration. So if a patient starts off stable at the beginning of the transport and we're arriving at the hospital and our patient is deteriorated, we're trying to find a way to keep track of all of those to find out why are we having a patient deterioration. Is it our crews don't notice the decline in patient? Do we not know how to manage it? Is it the patient was never stable in the first place and we missed something prior to sending it out? Are we sending them ground when they should have went air? But there's been...
The concern is that you picked up an uptick in this.
I've picked up probably, I want to say in the last month, a random PCR checking, so this isn't going through the hundreds of thousands of PCRs I get. I've seen probably about 6 of patient deteriorations. 6 to 8 of them.
Which is atypical. That being said, the sample size is really small, and so it's hard to say whether this is just a statistical blip and really has no clinical significance or real significance, or it may be useful just to track and trend this for another month or two and see if there's some persistent thing, as opposed to just a,
It would be just getting that information to see exactly how many we have. Because like I said, if I'm going through 100,000 PCRs and I found 8 of them, I've probably only searched through maybe 20,000 PCRs. I don't get to go through all of them. So it's either the hospital would have to report it or the agency would have to report, like, hey, there was a deterioration of this patient, here's the chart, so we can keep track of them and see what the trend of why it's happening.
Was there anything common linking those 6 or 8 charts that you saw?
No, some of them are transports, some of them are 911 calls, some of them were long distance transports compared from like Kingston to Westchester compared to Mid-Hudson to Westchester. There are different conditions. Some of them were vented, some of them weren't.
So I guess the ask in the short term is, I guess, we'll continue to track and trend this data to see if there actually, if it sustains itself as is or is just a blip. But in the interim, if your respective hospitals notice a history that sounds like a patient that shouldn't have declined has declined pre-hospitally and on arrival ends up in externus, just let us know, because then we can actually investigate to see if it was a clinical issue on the part of the crews. Any other new business?
One question regarding the supervisor. So is that no longer being considered a pilot program as part of the collaborative protocols? Yeah, I'm a little confused. You say that it's part of the protocols, but skills for the student to put it out. I'm not sure. You can help me.
So the protocol committee puts out protocols once a year in January to be implemented by July. They agreed to put in the SGA for EMTs if trained and equipped and regionally approved. And so we're just waiting for the policy statement to come out to that effect, to take it from being a pilot project in Hudson Valley to just allowing it to sunset as a pilot project and be approved for agencies to use in the protocols. And we didn't want to stop the pilot so that folks that were using it now continue to use it until the state comes out with their policy on it, and so that's where,
So once that happens, that's that.
yes.
Do you anticipate that would be July?
I'm hoping that that will be in the next week or two. For the state to put that out by the end of January so that people can just start using it and doing it, and
Downstream.
as a region, we're not tracking it anymore or anything like that.
Thank you very much.
Any other new business? Open forum? Motion to adjourn.
Second.
Next meeting, Monday, March 3rd. Tell your friends.